Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Dr. Neil Nandi. Dr. Nandi is a gastroenterologist and associate professor of clinical medicine at the University of Pennsylvania and specializes in inflammatory bowel disease. We talked to him about his personal connection to inflammatory bowel disease. We talked to him about serving as the director of patient outreach and advocacy for the South Asian IBD Alliance and how they got started. We talked to him quite a bit about sexuality and inflammatory bowel disease and how he talks to his patients about this. And we talked to him about an unusual side project he did when he was living down in Florida. Just a quick disclaimer that this episode discusses sexuality and contains sexual content, so it may not be appropriate for all audiences. And also, please be advised that the opinions expressed by the speakers are those of the speakers and should not be construed as medical or legal advice. Cheers!
Hi, everybody. Welcome to Bowel Moments. This is Robin.
Hey guys, this is Alicia, and we are so very excited to be joined by Dr. Neil Nandi. Dr. Nandi, welcome to the show. We are, again, very, very excited to have you.
Thank you very much for having me. It's good to be on with you guys.
Next question for you is our very unprofessional question of what are you drinking?
I am still at work, so I am drinking this fine beverage known as water. This is a fine vintage. Came out of the tap maybe 2 seconds ago. Yeah.
Is that a uterus on your bottle?
No. It's a ram, and it has a saying. Could kind of looks like a uterus, though. You're right, but it
does look like a uterus.
Fortune favors the brave. So that's why I got that.
I mean, uteruses are pretty brave. I'm going to tell you.
They are. Yes.
It feels fitting to me.
Braver than testes, I'll tell you that. Yeah.
Yeah. Doesn't take much. They're kind of scared little things.
They hide. They retract all the time.
No.
Just kidding.
You're not. You say you're kidding, but it's true. They do.
It's true.
I live in Minnesota. It's cold here. Yeah. Robin, what about? I'm sorry about that. Robin, what are you drinking?
First of all, we're off to a great start. I am having a day. I feel like we're all having a day on this call. And so I'm having a very delicious Bloody Mary.
Ooh, I love Bloody Marys. That sounds good.
Which, by the way, congratulations on the fact that your J pouch handled it well, and
Thank
the
you.
celery on top of it.
Yes, and celery and the Bloody Mary. J pouch took it like a champ.
Nice.
Very good.
Yay.
Well, cheers.
Cheers to the J pouch.
Alicia, what are you drinking?
It's whiskey with some smashed blueberries and lemonade and lime juice. Oh, I think it was supposed to be lemon juice. I had some lime juice in there and some cinnamon. But as I was mixing it, I got to the part where I was supposed to add the whiskey, and it was like 5 ounces of whiskey. And I was like, oh no. So I think I'm drinking the mixer for 4 drinks, but the amount of alcohol for 1 person. So it is a little interesting, but it's pretty tasty.
Looks tasty.
Cheers, guys.
Cheers.
There you go.
Cheers.
Well, Dr. Nandi, again, we are really excited to have you on because I have seen you in like various clips and social media and stuff, and you're always very entertaining and funny. So frankly, I'm stoked just to talk to you.
Thank you.
First of all, we're going to start out by asking you, like, what brought you into the IBD community? Why did you choose gastroenterology, and then why IBD as your specialty?
Yeah, absolutely. So I actually went to med school to become a pediatrician, believe it or not. And I thought I was going to be curing, pediatric cancer with gene therapy. That's what I thought I might be doing when I first entered. But then I went to med school, and I actually did not like my pediatric rotation. I loved the patients, I just didn't like the field. And then I loved surgery, and I loved delivering babies. I loved the surgical technical aspects I found of medical caregiving a lot. But then when I immersed myself in those surgical fields, I found that I was really lacking something, and that was like patient contact. And it also wasn't the type of medicine that I thought that I was going to do. I'm South Asian, but I didn't grow up with any doctors in my family, contrary to stereotypical beliefs. So, I really didn't know what it meant. In my head, it was always taking care of a patient, like really listening to them, taking care of them, being there for them. And so I found that medicine, internal medicine, which you do first before you do a fellowship or specialty, is kind of the best of all worlds. Like there's so many surgical or technical specialties within medicine, and GI being one of them. What drew me to GI illness, though, being Sherlockian in my approach to diagnosis, but was also able to do procedures on patients, and because the illnesses were really interesting. And then several things shaped me to become an IBD specialist. When I went to medical school, I did not know that you could go and become a doctor who only does Crohn's and colitis. I didn't know that existed. I thought you were a general gastroenterologist at best, right? But I found that my father had been diagnosed with Crohn's in the 1970s. I learned that much later in life and learned about what that cultural stigma and what chronic health and illness meant in new light, because he had his own issues. And then I had, college friends and med school roommates who ended up having, inflammatory bowel disease. So all these different experiences kind of shaped when I went into med school and residency and then in the fellowship that I would eventually one day become an IBD doctor. And what I find is it's incredibly rewarding because I have these chronic lifelong relationships that I've always wanted with my patients. And hopefully I'm making some of their lives a little better. And, I still get to have the procedural aspect of things, but I feel like I'm not just removing something, I'm doing something, I'm diagnosing, I'm helping them in some way too. So yeah, so that's a little bit of rambling of why I went into GI and IBD.
I love how you said chronic lifelong relationship, because I'm going to message my doctor now and be like, we have a chronic relationship.
That's right.
It just feels appropriate. It feels appropriate.
Well, it's important actually, because it's amazing, right? If you're a doctor, you're not hopping around jobs too much usually. You're there, and if you're lucky, your patients want to come back and see you, and so that hopefully means that you're doing a good job and helping them. And I'm 10 and a half years out of fellowship, and that was preceded by 10, 11 years of school and training, right? So it's a long journey. And so now that I've been practicing the art of medicine for just over a decade, it's amazing how many people I've seen get older and hit other milestones, right? Like I'm middle-aged now, and I can see that people who started out with me in their high school or college years, right, or graduate school, now they're going on to the next one or two phases of life, whatever those, if you believe in, phases of life, right? But whether they're having a kid or going to graduate school or going to medical school or becoming a parent, or just whatever it might be, it's been amazing, right? Because no doubt at some journey along the way in the last decade plus, IBD's gotten in the way, and it's something they've had to overcome, right? So that's huge. I mean, it sounds cheesy and corny, but I live off of it because it makes me feel like what I do is meaningful.
That's really lovely. And I think we've seen that in some of our other providers we've interviewed have said the same thing, that really what was attractive to them about working with the chronic community or chronic disease community, IBD in particular, was again those relationships that you build and you form. And I think some of our pediatric gastroenterologists have struggled with letting some of those go too, to go off to become adults, because they do have such deep relationships with their families and their patients. Yeah. And so it must be rewarding, but also hard at times, I would imagine.
100%. Yeah.
So you mentioned your dad had Crohn's disease. Did you know about that growing up? Because you said you sort of learned about that later. So
yeah, I didn't know about that till I was much older, still a kid, but not when I was young. He was he immigrated to the country, United States, in 1970. And then several years later, 1976 or so, he ended up having severe abdominal pain and, blood in his stools and a mix of symptoms that were eventually diagnosed. Again, this is mid 1970s where, IBD was still in quotes a new thing, right? Even though it had been around for 30, 40 years at that point as a known diagnosis. But he was diagnosed with, small bowel Crohn's, ileal Crohn's. And at the time, he's a South Asian guy, right? Brown man from India in America. And he was told, no way, this is a, Caucasian, European, Jewish disease. This is not of a Hindu, get it? But of a Jewish disease. There's no way you could have Crohn's. And his diagnosis was really kind of pushed aside initially until another South Asian gastroenterologist that he happened to meet, examined him and took a look and had been learning about Crohn's and took a chance. And the only thing that made him better was prednisone, right? Because it's either prednisone or surgery, was nothing else, right? So prednisone helped him, but it wreaked havoc on his body. It ended up giving him a vascular necrosis of his hip. He should have had a hip replacement years prior, but he lived with the limp and the jagged hip of in his joint and limped almost his entire life because he didn't want to take a chance of going to surgery because he had to, work and provide for not just in partnership with my mother for me, but for his family back home, right? So he felt, this responsibility and just kind of lived with the pain and chronic steroids. But yeah, so it kind of, in quotes, burned out, kind of, where it became less active. And I think there were flares that he didn't tell me about in retrospect, that as a young person, hey, Dad, you okay? And he would just kind of bear through the pain and pretend. So it wasn't until I was in like medical school, or no, college, that he kind of said, oh yeah, here's these x-ray films, and he pulls them out of the closet, and he goes, this is where I have Crohn's. And I'm like, what are you talking about? And that's how we started talking about, when I was older but still young. And yeah, it was kind of out of the blue. And that's where, other interests that we might get into have kind of shaped my career, not just for him and or South Asians, just my approach to what's the stigma of disease, And then we've come a long way. We have a lot more to go. We've come a long way, but he's an example.
Yeah, I can relate to that. My dad had multiple sclerosis, was diagnosed when I was a teenager, and he sure as shit did not talk about that. Like, we didn't talk about it. It was there, but we didn't talk about it. And he finally actually said it aloud to me and acknowledged that he had this when I was 27 years old, and I was working for the National MS. And so I had fundraised. I'd been like very open and active about MS for years at that point. And that was when he finally said something to me.
Wow.
At 27, when I was 26 or 27 years old. And I was working for, the organization that covered his disease, basically, as a person who handled patient issues. I'm a social worker. So, I was doing their patient assistance. And that's when he finally acknowledged it first time. So 11 years after he was diagnosed.
Wow.
But
yeah, that's the power of stigma and denial,
Mhm.
right? And yeah, it's a powerful thing.
It very much is. Let's talk a little bit about that. You said this has sort of shaped some of your interests, and I know one of the ways we were introduced to you is through Tina and through the South Asian IBD Alliance folks.
Yeah.
And so, talk a little bit about your involvement there, and sort of what got you involved in that, and what have you done, and what's rewarding.
Yeah, so that is one of our proudest ventures that we've embarked upon. So all across the globe, through every decade, for the last several decades, in the Western countries and the countries that are not considered Westernized, we see that there's an increasing prevalence of inflammatory bowel disease, Crohn's and ulcerative colitis. And so it's every color of skin can be affected by it. And growing up in this medical culture, it wasn't something that was preached to me or taught to me formally. And once I became an attending and started taking care of patients, I started taking care of lots of South Asian patients. And my gosh, the same stories, abounded. Like, whether they came from Pakistan, Nepal, Sri Lanka, wherever, Bangladesh, they or born here but of South Asian descent, they'd say, I've had these symptoms for a long time. I bring it up to my family, but they would just give me all these different therapies, homeopathic or Ayurvedic therapies, or just kind of dismiss it. Or if they finally did get a workup because something major happened, right? Go see the doctor, get hospitalized, emergency room visit. When they got a diagnosis, a label of Crohn's or colitis, there was definitely a stigma. And then family would bring up the karma card, which is, oh, you did this, like you did X, so you deserve this, right? Because you did this, cause and effect. And that's a horrible thing, right? Like, I don't know a single patient who has ever deserved this illness, It always happens. I always say, I have a saying, like, bad things happen to good people. And like my patients, our community are some of the sweetest, lovingest, most beautiful people in the world. They put up with this illness and survive so much. So they didn't deserve this, right? So there's this cultural stigma. There's also the karma aspect of it that I hated. And also the marriageability component, which we like to talk about, which is, oh, now who's going to marry you, right? My goodness, right? Nobody's damaged goods because they have a chronic illness, right? This is something they're going to overcome and have to deal with, but they're beautiful people, right? And deserving of companionship. So these are some of the things that led around to finding like-minded individuals like Tina Aswani Prakash, owner Crohn's, or one of our dietitians, Neha Shah, and several other physicians and nurses that I know. So we started doing some webinars we had actually talked at several conferences. Hey, why do we do like a South Asian IBD thing? And it was just very informal. Let's do a talk or a meetup or a group thing. We did these digitally, and then the pandemic hit. And because of the COVID pandemic, I had a channel on in whatever free time I had on my website, where I would do YouTubes and stream these webinars about COVID, and it kind of was useful to talk about South Asian IBD. And I was focusing on IBD patients, and that kind of morphed into, why don't we get more people interested? And, Tina is really the glue that kind of brought all these different various interested parties, because she'd been passionate about this for a long time. For listeners, she's South Asian as well. Her father had Crohn's, and Tina has Crohn's. She's open about that. And so she kind of brought all these other like-minded people, doctors and patients and dietitians, gut psychologists all together. And we kind of came and formed the South Asian IBD Alliance, SAIA, also known as SAIA. You can learn more about it at southasianibd.org. And we achieved nonprofit status last year in October. We've published a few small papers in our name, and I say small as humbly as possible, but we were very lucky that our GI societies welcomed us, and we've written some papers on the DEI, or diversity, equity, inclusion aspect of considering South Asian IBD. We've written a paper on identifying opportunities for research to find solutions to overcome some of the barriers to getting therapy in IBD. And we have 3 arms: research committee that's developing research ideas to look at South Asian IBD response and characterize the disease. 2, education committee, which is developing continuing medical education for South Asian professionals. All colors are welcome, but how do you talk to the South Asian patient and family member about IBD? And then the other committee, the patient outreach and advocacy committee, I co-chair that with Madhura Balasubramanian, who's a patient advocate from India, and also Dr. Sumit Bhatia, who is a South Asian IBD specialist in India. And the 3 of us have several other partners, and we basically do almost every other month webinars on YouTube. We stream globally. We invite global famous docs from across the world and patient advocates to talk about sexuality and intimacy, pelvic floor dysfunction, biologics, clinical trials, diet, how to incorporate South Asian diet, and I find a lot of gratification from that.
That's awesome. And yeah, we've had Tina on and a few other folks that have that are part of SAIA on the show. So definitely I'll make sure I link to those episodes so folks can find them, because they have been really fascinating conversations. And it's really fun to hear what everybody brings into why they're joining SAIA and what they hope to accomplish. But it's been cool to see how fast it's grown too. I was telling Tina how impressed I am that you guys really just came out of nowhere and then just started kicking butt and taking names. So that's awesome.
That's because we have an amazing team of docs and patient advocates. And what I love about SAIA is it's patient physician co-founded, and we're very interdisciplinary, working with also all different types of stakeholders in the process. Yeah. And what I do hope to get from it, though, is that the more we talk and educate our culture and descendants of our mother culture, right, South Asians, it helps to hear about IB or education from somebody who comes from that culture, right? And it might be similar content and same content at times, but it makes a difference, right? And there are definitely cultural nuances and differences. And that buys into the adoption, it buys into destigmatization. And my mission is not just to connect to the patients, but to their very family members, their parents or grandparents or siblings or spouses or partners. I want to connect to everybody so they understand how to support the patient and how not to be a barrier to early treatment, early therapy, whatever that might be, but to be a partner in it and help their loved one get promoted in healthcare, get access to healthcare. That's the dream.
Yeah, I think it's really important, just based on the conversations we've had, with the other folks in SAIA. It really is important to ensure that the family is incorporated into these discussions, because it is, needing the community to really understand what's happening with the patient to really help make sure that they're getting the best care possible. And, our conversation with Neha was so fascinating because of just like, how do you take guidelines that are sort of more towards this very Western diet and make sure that patients are really seeing themselves and how they can eat, because it is such a problem with this community. It's such a question mark for them, is what do I eat? How do I eat? How do I keep myself well in that way? I'm curious. So you mentioned Ayurvedic health and medicine. Talk about what that is, number one, because I think I got it, but I'm not sure. And then also, are there aspects of that you have found that patients find really, really helpful, that you do talk to other people about, that are maybe, white folks like me, or like, actually try this thing? So talk a little bit about that side of things, because I'm very curious.
Well, I am not an expert at Ayurvedic medicine or Ayurveda itself. I will never claim to be so, but Ayurveda is an ancient culture and tradition that is millennia old. from the dawn of time in South Asia. And they've passed on different types of therapies and herbals and medicines and treatments, rituals even for healing physical illness, for healing mental illness, right? So even yoga can trace its roots back there. But in terms of Ayurvedic medicine, it's often the application of natural products, natural herbs and such to healing. And so, there's many different types of Ayurvedic medicine. They have, it's similar and akin in some ways, in many ways, to ancient Chinese medicine. Okay, where they use herbals as well. And this is, Native Americans and any early culture learned how to use the natural properties of the plants around them through trial and error and developed experience, right? And some of those we're finding in this day and age actually have science to back them up. I have to be fair and balanced about this. Many we don't know anything about, and others we've said, no, there's no science here. And some, and there's actually a number of cases we have harm, right? So there is a value to having science backing these things up. In Chinese herbal medicine, we have red yeast rice, an anti-inflammatory, from which we've derived statins for anti-cholesterol benefit. And it turns out they have an independent, separate benefit of an anti-inflammatory effect in the body that's being studied right now. Who knew, right? Well, science did, right? And not even science, sorry. Who knew, Manning? Millennia ago, right? The Chinese, practitioners knew. In Ayurvedic medicine, the perfect example is turmeric, and turmeric with black pepper extract, and high dose turmeric and mild ulcerative colitis compared to placebo. There's at least 3 clinical trials that show that it can induce remission and mucosal healing. That's a huge, big deal, right? Because there's very, very little to no risk of taking turmeric. You just might get your fingernails yellow. That's about it. Maybe your teeth. So Ayurvedic medicine, there's a role there. But sometimes in South Asian culture, we can see practices and treatments that really are of not benefit, and where patients are told, well, hold on a little longer, adjust the dose, or just do it for a couple more weeks. And what happens is that's a delay in therapy, delay in getting an evaluation to get access to the therapy in time. And if we introduce that therapy too late, then we can have a lot of bowel damage and poor outcomes. So I think that we need to find a balance. We need to do more scientific research on these therapies, look at every single possibility that they can help. And we have precedent to say that some of them can. So we have to keep an open mind. But while we're doing so, in the absence of evidence, we need to talk with our patients and educate them that maybe we can do both. Maybe one is complementary to the Western therapy. And I think that's, in my opinion, a fair approach to how to balance Western medicine with complementary medicine.
This is going to be a curveball question. In your 10 years of practice, I'm sure you've treated lots of different patients. Do you find similar stigma in other cultures and ethnicities where it's not exactly the same, but there's some correlation and some comparisons that you could make with other cultures outside of traditional white, Western, blah, blah, blah?
I'm glad you asked that, Robin, because that kind of gets to why do we have a South Asian, alliance, or why do we have other, cultural organizations? So yes, the themes are very similar. Maybe not the karma aspect. They may not call it karma, but they might have some other word for it, And I see you nodding. There's always like, you did this, right? Whether it's ay Dios mío, it's God, or it's another force of nature, right? It's something that you might have done, but whether it's the stigma of talking about poop that we all poop. Isn't it ironic that we don't talk about it, right? We all pass gas, but we run from the room. Well, some of us do pass it, right? But it's too stigmatized, right? We don't, when we have a chronic health illness, it has this impact on our, relationship status or what's not. And then the family dynamic, the cultural dynamic is, let's not talk about it. Well, let's not talk about the wrong kind of people. This is true no matter what color, what culture, what language you're from. We need culturally competent care, which is basically, we need people who look like you and talk like you, right? To talk about disease to you, right? Because it's easier and better accepted. You're breaking down the color barrier, the language barrier, that barrier, whether you believe it's there or not. And so, yeah, many cultures can benefit from cultural adaptation and taking what we know about IBD or any chronic health illness and filtering it through the lens of their culture so it's more palatable, digestible, acceptable to the patient and their culture and their community.
Good answer. I like it. I'm going to take us down a different path now, because one of the things when I was looking you up, you just recently did a talk on sexual well-being amongst ostomates, which I think is really awesome and such an important topic. And Robin and I had talked recently when we just our, episode that came out here just a little bit ago, talking about sexuality and how we've touched a little bit on it, but we haven't delved in too deep. So if you don't mind going down that path with us.
Absolutely. Yeah.
How do you talk to your patients, not necessarily ostomates specifically, but just your patients in general? At what point do you bring up sexuality within your conversation with them or within your evaluation when you're starting to work with a patient? And then one of the things I've joked that we are the J Pouch podcast in a lot of ways. And so certainly there are some aspects of people's sexuality that may be impacted by these types of surgeries. So especially when you're talking to somebody who may be having some sort of procedure or surgery that may impact their sexual ability and well-being and their choices that they can make to be sexual. So just in general, that's I gave you 17 questions right there. So feel free to
it's all good. And I'm glad you're asking the question. I mean, so yeah, it depends on, one, how do I approach it? Well, it depends on the patient, it depends on my rapport. I often find in retrospection of how I practice that I kind of adapt my personality and my approach to every patient, right? Like some patients are going to be really, silly and light and joking, and humorous, and others might be more reserved and conservative. And I need to respect that vibe and earn some more trust. And I always think about the patient's journey before they ever got to me, if I'm meeting them for the first time and have no history built with them, I have no idea, so I usually wait a little bit to get to know them. But then once I find it, I don't do it during active disease flare and they have to go to the ER. That's not the right time to talk about sexy time, like as I call it. So I always find in general, the best time is a well visit. And an IBD well visit, it means things are good. We're just touching base. Meds are good. Preventative healthcare checklist. And then I ask them the question, look, I ask all my patients this question at some point as I meet them, but what is your preferred member and sexual orientation, and how's your sex life, and if the patient's again, I tailor it. If it's somebody I've known for some time and we have a good relationship, I'll be very forthright and upfront. Let's talk about sex, and how's sexy time. Other ways to approach it, and I'm giving all these examples because I'm hoping not just patients but clinicians, I think, listen to you guys too. And I'm hoping clinicians can take something away about how do I talk about this to my patient. But I'll ask about, how's your relationship, right? I ask because I'm hoping that your, IBD doesn't get in the way of activities, and like with, what's your favorite hobby? Can you golf? Can you cook? Can you spend time with your kids? How's your relationship? Is it healthy? And oftentimes, I've developed enough rapport at that point. They'll be like, oh, well, I hate my spouse, or no, things are good. We're going away on a vacation, and I'll broach the subject. I'm like, well, good. One thing that we don't talk enough about in this society is sex. And I always give it a context, right? So this is the conservative approach, right? We don't talk about poop enough. Every one of my patients gets that. They nod their head. And then I say, we certainly don't talk about sex enough. They nod their head. And yet Instagram is full of poop emojis and half-clad people, right? So we know everyone, it's on their mind, right? So when I broach it in one of these different ways across the spectrum, it gets them to open up and ask. What I'm looking for is just to ask if they're having a sexual or intimately fulfilling life. And so I'm always clear that intimacy does not equal sexuality or intercourse. That's an extremely important thing because that's not true for a lot of people. Don't have satisfaction through just intercourse at all. It's more about other forms of intimacy, other acts. So I broach the subject that way. And just because I brought it up, if a clinician is listening to this, and you're thinking to yourself, oh my God, I'm a GI. Why would I ever open up that can of worms, right? What do I know about that? I don't even know what to do about that. Who am I to ask? I'll tell you what, I used to think just like you, but I opened my mind, and I found that when I asked the question, my patients were relieved. They were, one, surprised in a positive way. They felt relieved because they didn't know who to ask. They didn't think they could ask me. And some of them wanted to ask, but felt embarrassed or thought, for whatever reason, they made up an excuse because they're good people. In their mind, they made an excuse for me. But honestly, patients feel relieved when you ask them. And what you're doing is you're not opening up a can of worms. You're identifying any issues, and then you're triaging it to a specialist. Because guess what? You're a gastroenterologist. You probably don't know jack diddly squat about sex and sex counseling. But guess who does? sex therapists, sex counselors, pelvic floor therapists, urogynecologists, men's health urologists, right? There's a lot of other people who have spent their entire life and career helping patients live a sexual and intimate, fulfilling life. And so your goal is relieve their pressure, ask the question for them, and then triage to the right specialist and put them on the right track. Otherwise, when you don't do that, patients can go their entire lives without having these questions answered. And, Alicia, Robin, I think that one of the most beautiful things, the core thing about being human is being intimate. It can just be holding hands, sharing a moment, a kiss, a hug, but it's intimacy. And if you feel uncomfortable to participate or engage in intimacy, that might be normal. It might be normal for you, but by and large, there's something that may prevent that from happening. And I think a lot of patients would like to be intimate. So I think it's our duty to try to make sure that we're not just razor sharp on the GI, but we think about everything as a whole.
I think that's really the nature of being a provider who works with people with chronic illnesses, though, too, is that, and Robin and I have talked about this before, you kind of become the primary care physician for people who are living with these things. And so it does mean you perhaps end up maybe having some of these conversations that typically somebody might have with their, gynecologist or with their primary care physician or somebody else. When your IBD is the thing that overarches all the rest of your health, and you end up talking to your gastroenterologist, about some stuff that maybe is not something you normally would. But there are some aspects of having IBD that may affect people's sexuality. Like, for instance, isn't there like some aspects of IBD, for instance, that, certainly, abscesses and fistulas are real problematic. But is there an aspect of it that causes like some men to have, their words are gone.
Erectile
dysfunction.
Yeah.
Thank you, Robin. Yes. Some erectile dysfunction issues.
Yes, absolutely there are. And that kind of reminds me of that great Super Bowl commercial. You guys see that? The PE? It was like premature electrification. I love that.
Is it?
It was
great.
I
thought there was the Peyronie's one. I keep getting the Peyronie's one with like the bent carrot commercial. And I'm like, I do not, I get a lot of IBD commercials, but I don't understand why I'm getting that one. So sorry, I didn't see that commercial apparently.
That is an illness of the penis. That's true, Peyronie's. But no, this one's like a electric Ford F-150 commercial, and having like, Robin gets it. Robin knows what I'm talking about. You got to YouTube it. But anyway,
I missed it. I'm gonna have to find it.
It's good. It was fun. They took a chance, paid off, I think. So pure electrification, PE. So no, in terms of ED, erectile dysfunction, that is a real thing, and it's also something separate, which is performance anxiety. So for men, we talk less about men's sexual health. I am biased because I'm a male, but I feel because I do educate in this space, we do have not enough sexual health talks. We have slightly more geared to women than men, but I think it's men's fault. And let me clarify. I think it's men's fault that we don't have enough, because most men are raised not to talk about sexual health dissatisfaction or erectile dysfunction or performance anxiety. Most men are raised in cultures or families or communities where that's very taboo, and it's less masculine or machismo, whatever that bullshit means. And so they live, in dissatisfaction. So in terms of IBD, certainly if you've had any type of pelvic surgery, whether it's as, just a diverting, low diverting colostomy or ileostomy, where you've had a J-pouch creation, maybe you've had a subtotal colectomy, or definitely a total colectomy. Definitely the deeper into the pelvis we have to go, nerves can be injured unintentionally that are very, invisible to the eye at times to be seen by the surgeon. And that can lead to, either painful ejaculation, retrograde ejaculation, where it goes the wrong way, it's very painful, or you can have erectile dysfunction, where you can achieve the erection that you like. Some of our patients, here's another thing for ED, regardless of having IBD, if you're a male and you have family history or personal history of peripheral arterial disease, which is blockages in the arteries from plaque buildup, or you're a tobacco smoker, right, where that accelerates that, right? Or you have really uncontrolled diabetes. These are other reasons that can accelerate, that are concomitant, incidental, coincident to you having inflammatory bowel disease, but they can also give you erectile dysfunction, because ED is common, whether you have IBD or not. It's if you've had pelvic surgery, then it might be increased. And if you've had severe disease, that might also actually impact your ability for dysfunction too.
Not to bring it back to women, but just for a second. We do have a lot more female focused education in IBD. And also it's focused on fertility. So similarly to men, women, we're not allowed to age with IBD. Like they only do education where it comes to younger women that are of childbearing age or that want to have children. Not all women want to have children. So I feel like you are correct. There is a lot more education focused on women, but it is very narrowly focused on that one phase of life around fertility and being able to have children.
You know what? I think that is an excellent observation, Robin. I'm glad you brought that up. You're right. We hyper focus on that, right? And part of that is very appropriate in the sense that, there is some voluntary childlessness. Some women, studies have shown, believe that they can't get pregnant because they have IBD, which is not true. But the other equal and a very valid point that you brought up is not everyone wants to have children, and that should be socially acceptable and okay. But the education in sexual health shouldn't stop there. I think that's part of your point, right? And I agree with you that wholeheartedly. Like if you come to one of my talks, we talk about, how do we utilize sex toys for both men and women? How do we engage in partner communication? How do we engage in just sexual health? Forget about reproduction, right? And yes, I agree. I would love to go around lecturing more on it, and I think we need more more education on it for sure.
Agreed, 100%. I would like for you to go around lecturing more on it. Please make that happen.
Can we talk a little bit, because this did also come up after we had Josie McGarva and Stacey Collins come on to talk about Congress. One of the things I asked is if there was any discussion about sexuality, number one, but also if there is some acknowledgement of how do we ensure that people that are in the LGBTQI plus community to feel very safe around this as well, because that can be a real issue. I mean, speaking of, not feeling judged and not feeling heard, this is another community that I think at times takes a little bit of extra care and a little bit more of putting yourself out there to ensure that they feel comfortable talking about this. So how do you handle patients like that?
Yeah, I'm glad you asked, because actually, I live in Philadelphia, city of brotherly love, and we have a large community here. First off, I want to start by saying when we talk about LGBTQ plus, I mean, that is so unfair to like lump everybody in. It's like when we talk about Earthians, right? People from, it's like, you kidding me? There's so many different types of Earthians, right? Humans, right? Obviously, it's not fair, right? So there's all these different nuances. And when it comes to inflammatory bowel disease, one, there is sexual health literature in IBD, but there's a paucity of it still relative to what we need, a lot of unanswered questions. Two, when it comes to anybody who's not heterosexual, we have almost nothing. We need to do better studies. We need to have better research into this. And moreover, we have to have focus groups, right? Where we have, people from these different types of sexual orientations who have IBD come and talk to us, right? And that's something I've been talking to several people about trying to organize. It's something in process. There is, in Philadelphia, we have a large, neighborhood, is what we call it. And so I happen to have lots of, well, not lots, but a good number of patients who happen to be homosexual and have some form of Crohn's or colitis or have an ostomy. And so most of my experience is there, and I've learned from my patients because nobody taught me the right questions to ask. And basically it was me asking that opening intro question, hey, how's your sex life or intimacy life? How's that relationship health, for you? And then asking my patients, doing my own little one-on-one, focus groups. So there's not enough literature. We need to have better, research into this. There are some people at Mayo Clinic and several other institutions that are trying to open this up. I do recommend, so I do have patients in the area who have their own support groups, if you will. And I think that helps. There's a couple of organizations that embrace this topic. I'm thinking of Girls with Guts, actually, who actually recognize this for many years, actually, that this is an issue. And so there's a safe community and safe haven within there, right? But I don't think we know enough about how to support these individual communities based on sexual orientation. I have my tips and tricks that I share, but they're very few and far in between, and I'm still learning.
Yeah, I think in general, we're all still learning in this, but I think it's really important. And I love the idea of bringing focus groups together and getting a better understanding of how we can open up these conversations with the community. Because in general, again, like, if you don't see yourself represented, it is a lot harder to feel connected to this topic and to your doctor. So
yeah. I'll just give two examples of things that I wanted I realized I talk so much, so I didn't say
no, I
them.
love it.
But one is, when it comes to anal intercourse, anal intercourse is not just a homosexual practice, but is a heterosexual practice. It doesn't matter. And so if you have a negative reaction to that comment, screw you. And listen to this, basically. There's a pudendal nerve that has 3 branches. One branches out and innervates. It gives you orgasm and pleasure. It innervates the clitoral head or the penile head. The second branches to the anal sphincter, and the third is in between, the perineum, between the genitalia and the anus. And that's a very erogenous zone. And so there is a scientific medical reason why people have pleasure. Okay. If you happen to have your anal sphincter intact and you think it feels good to take a poop, there's a reason for that. Okay. So I'm just trying to give people concrete things they can relate to, but anal intercourse is a normal thing. Now, imagine that you have a perianal fistula, like you said earlier, Felicia, or you had a completion proctectomy and you don't, right? You don't have a anus, right? Then how do you have pleasure, right? Or let's say you have your pouch. Let's say you have a J pouch, right? And your doctor says, oh, you can never have, anal intercourse again, right? We have to challenge all these things. There's no absolutes here. There's ways that we need to approach this, and it's going to vary by patient. For a J pouch, talk to the surgeon. What's the anatomy look like? Are there sutures? If there's a ceton in place or active disease, probably want to avoid anal intercourse until we get that healed for you. If you have, no anus, right? Depending on the anatomy, the strength of the muscular floor, depending how delicate or strong that area is, how far out you are post-op, because it takes many months to heal post-operatively from that. You might have, pleasure or not, right? From having that area just stimulated with caressing, right? But this is me getting different snippets and tips from different patients. And again, it differs. It depends on the patient. When you think about cunnilingus, right? Or fellatio, and you're, lesbian or straight, doesn't matter, right? And you have a fistula or, you have a boil or abscess, right? These are things you have to consider, not just in how do you engage, right? But maybe why there's not partner engagement, right? Maybe they feel embarrassed, right? Maybe they need to talk about it. Maybe we need to have communication between partners so that there's not this tension. Most of the time the partners are just trying to not ask for their needs to be fulfilled. So this tension builds. But then once you have the partners talk and communicate their concerns and that, why they may or may not feel bad about not being able to participate, the tension dissipates. They find other ways to find intimate fulfillment, maybe beyond sexual fulfillment, right? And see, these it's so complex, but it all comes down to how do we make sure that not just heterosexual couples, which are very important, but every type of individual patient, regardless of orientation, how do we make sure they're being fulfilled intimately? And it's so complex. I'm glad you asked, but I wish I could have an answer for all.
I'm going to add on there too, because you mentioned some pretty severe situations like the fistula, that even just going to the bathroom so many more times can cause soreness, rawness, reasons why you would not want to engage in intimacy with your partner. And so like just normalizing that part of it too. I mean, it doesn't have to be something that's so severe or serious to affect your sex life when it comes to IBD because of all of the other symptoms that come along with having IBD.
100%. That's a great point.
And mix in a big dose of fatigue and anemia, and maybe you're too tired. This is going down a real rabbit hole. I mean, we've had a couple of ladies in particular that have some Barbie butts that they love. Is there a way when somebody is getting a permanent ostomy and that is part of the surgery is to get your quote unquote Barbie butt? Is there a way to modify for folks who maybe still want anal intercourse? Is that something you can do?
The answer is yes, but that's a very, very simple. It depends on the need for, right? You could have a subtotal colectomy where you have a Hartman's pouch, where the rectum, if you were to go in, it's just a blind ending pouch. But if the disease was bad enough, sometimes we're recommending a colectomy to remove that, because otherwise it needs surveillance. You need a little mini scope in there for dysplasia or precancer risk, if depending on the situation, of course. And so rather than having these frequent exams, right, annual exams, you might elect to have it removed or not, right? Also, if you do have like a closed pouch system, there are patients who have that, then you have to be careful that you can't just insert anything and everything up, because you don't want to cause a perforation either. So it's a great, interesting question, but I think there's a different use case scenario there in terms of insertion, physical insertion. But you remember I said about the erogenous zones, or erogenous innervation of the pudendal nerve from the sacrum and those three branches, right? There is a tremendous amount of arousal and pleasure that one can actually derive from caress and touch and temperature, right? And I'm not saying you hold something hot there, okay? But I'm just saying, there you go,
Maybe
right?
not.
But there's all sorts of ways to create nervous system stimulation, if I am to be sterile about it. But it's all about sensual touch. So there's other ways.
Got it. Yeah, that was a bit of a curveball for you on that one. But also, I want to know who Hartman is and how he got the joy of having this type of pouch named after him. But that's probably a different topic for a different day.
That's a different topic, but it's more than overdue that I should learn that. I love medical history, and how have I not thought about that? I feel like I've looked it up, but I can't recall, so I feel ashamed if I did, but I need to look that up myself.
Please text me afterwards and let me know who Hartman is and why he has this pouch named after him, because I'm like, we know who Dr. Crone is. We got that one.
Yeah,
but
right.
I'm guessing he's a surgeon. Did you know, by the way, that although it's named Crohn's disease, there's two interesting things about the disease named Crohn's disease. He had actually two other colleagues. One was, I believe, Dr. Oppenheimer. I think he was a urologist. And another one who I'm blanking right now, who was the pathologist, who actually was the one who did the post-mortem, or post-resection pathology samples and everything. And back then they used to put the names in alphabetical order. And so Dr. Crone got his name as first author. And then did you know that he actually reported the first round of the first series of Crohn's? And not to say that he did make a contribution there. I'm just saying it's not called Oppenheimer and the other gentleman who I'm blanking, but I think they all deserve authorship or credit for the disease recognition. At the same time, that was 1932. The first case series published. But I think as early as 1918, there was a Polish surgeon named Leśniowski who actually reported and documented Crohn's disease in the literature there in Polish medicine many years prior to it being reported and documented and characterized in America. And I am told that in Polish medical schools, this disease is known as Leśniowski Crohn's disease, or sometimes just Leśniowski's disease. So
I was just about to say, so I have Leśniowski's disease.
Are you Polish?
No, but if he was the first person to document it, I feel like I need to just change it.
That's right. Exactly. Yeah.
When people ask me what I have now, it's Leśniowski's.
That's a harder one to say. Crohn's is a lot faster. And I don't know how to spell the other one, so that's not going in the show notes. Sorry. I'll look it up maybe. Dr. Nandi, I'm going to take you on a completely different journey with me.
Uh-oh.
I would like you to tell us how you decided to moonlight as an actor.
Oh, God.
Yes, sir.
And a great little flick
sir.
called Tie the Knot.
Oh my gosh. How did you find that? That's amazing.
It's called the internet, and everything lives there forever.
It does. No, I'm actually really happy about it. It was an exciting time. It's just so funny that people find that occasionally. I have patients who are like, Dr. Nandi, I did my research on you. They'll bring up all the papers that I published, and then they'll be like, and I've seen your movie. And I'm like, oh my gosh. But I was a fellow at the University of Miami, where I was doing my GI fellowship, and didn't know a lot of people had a couple friends there as I was a fellow. You work long hours, and on the weekends when you get a weekend off, you go out and socialize, and met some people, and they had written an Indian American rom-com, and they wanted to film like a pilot. And I am by no means an actor, if you can't tell, but they needed Indian actors in Miami. Now, mind you, everybody who looks Indian in Miami is Latin. And so they went to the Indian professional community, doctors, lawyers, engineers, nurses, dietitians, right, the psychologists, and they just found this group of people, and they're like, oh, hey, you want to come to, somebody's house in the burbs and film this on VHS? Doesn't sound shady at all, right? Doesn't sound shady at all. So we said, sure, we'll go. And a couple of my friends, three of us went over to this new friend's home, and they assigned us bit parts. and I got the bit part of a side character in it. And the script wasn't even fully finished at the time, so they asked us to ad-lib on camera with other people, and it was really fun, and we had no idea where we were going with it. It was just a lot of fun. Yeah, and so anyways, nothing came of it. And a couple of years later, many years later, after I finished fellowship and I was a junior faculty, the writer, who's a friend of mine, he's a great guy, Shuja Paul is his name. He had moved out to Hollywood and sold the script to a producer in Hollywood. And they're like, look, we looked at all the VHS tapes. And the producer of all the people that were in that pilot, this was just, it was never edited, by the way. It was just something, something simple. Because out of all the people, he wants you to come back. But don't worry, I told him, you're now an assistant professor, you're very serious, and you teach. And I was like, well, no, this might be interesting. One, you're not joking, because I'm not joking. I was like, two, you're going to pay for me to come out there? They're like, yeah, we'll pay for you to come out here. But that's it. I'm like, okay. So I flew out there. It was like a real Hollywood set and real lighting design, real producers, cameras, makeup, everything. And yeah, Tara Reid was one of the co-stars of the film, and I got to meet her briefly. She was really sweet, really nice. And yeah, it was like such a fabulous experience to be on set. It was really cool. And I'll never have that experience again. And that's why I did it. I was like, what are the odds that I'll ever have that happen again?
Never say never.
That's
Somebody
right.
might suddenly decide they need you in a movie, but that is so fun.
That's a very low budget movie, and they're very desperate if that happens. But yeah, it was a lot of fun. It was a lot of fun.
That is so cool. We have only celebrities on this show, Alicia. We have Dr. Nandi and Dr. Kwapish, who is on Canadian TV. So,
Dr. Nandi, so last question for you is, if you had one piece of advice for the IBD community, what would it be?
Speak up. Speak up. And that means a lot of different things for me when I say it. For patients, it means speak up, advocate for yourself. And I think that's part of what a great thing this podcast does is it shows patients how to speak up for themselves, the language to use, the topics, that you're not the only one having these symptoms or issues. You could speak up, right? Two, for clinicians, what does it mean to say speak up? It means that if you sense that something is wrong, something is not right, ask. It's not just about sexuality, it's about anything. So speak up. And when you see, just together, right, we see that in this world of medicine, 2023, we still don't have flying cars, right? We don't have the adventure future that we want, right? We see a lot of atrocities in this world, and a lot of people don't speak up. So I think it really, I mean this in the global sense of speak up when it comes to your own healthcare, speak up when it comes to a patient's healthcare, to a colleague's health, speak up against, insurance companies when they are in the way, speak up when insurance companies do the right thing and help a patient, that does happen. Speak up. We can't speak up enough.
this has been such a delightful conversation. Thank you so, so much. I have enjoyed it so much. I hope that we can get you to come back because I still have a list of things that we need to talk to you about and ask you questions about. But for today, I'm going to say thank you so much again. And thank you for everyone who's listening. And cheers, everybody.
Thank you, Rob and Leisha. Thank you so much for having me. Hi, this is Dr. Neil Nandi. If you enjoyed this episode, please rate, review, subscribe, and share it with your friends.